Filipinos can now access the services of Mount Elizabeth Hospital, Singapore through the Patient Assistance Center. Visit our office at the ground floor of Marco Polo Hotel Ortigas Center, Pasig City, and book your stress-free medical journey with us. The Patient Assistance Center connects Filipino patients to the world-class medical care of Mount Elizabeth Hospital.
I am glad I discovered the concierge services of Parkway Hospital's Patient Assistance Center to provide the necessary support I need in my travel and medical arrangements. Give the Patient Assistance Center a call and let them do the rest for you.
A smooth medical journey from the Philippines to Singapore is now within reach. Patients are provided with fuss-free access to quality health care of Mount Elizabeth Hospital, Singapore. Visit us at the Patient Assistance Center at the ground floor of Marco Polo Hotel, Ortigas Center, Pasig City.
Good afternoon, everyone. So welcome for this afternoon's learning session on CAR T-cell therapy. We are grateful for everyone who joined us on this lecture for this afternoon. So before we begin, I'll just read out some house rules. First is please to pose a question to the panelists. Please post them via the Q&A feature. Second, the attendees are encouraged to update questions to be answered first. And please chat with the panelists or attendees via the chat features. Your camera and microphone are turned off during the webinar. So I'm very privileged to introduce the president of the Philippine College of Hematology and Transfusion Medicine, Dr. Angeline Mirasol, to give us an opening remarks. Ma'am.
Thank you, Alma. On behalf of the Philippine College of Hematology and Transfusion Medicine, a pleasant evening to all. I hope everyone is safe and well. Tonight, we will have another continuing educational activity. This time, it is from our partner, the Parkway Hospital, Singapore, with our invited expert speaker, Dr. Dawn Mya. I hope I pronounce her name right now. So she will be discussing on CAR T-cell therapy, the hidden possibilities. So this will be moderated by our very own Dr. Alma Reyes Calavera. Allow me to thank Ms. Dory D. Aquino and her team from Parkway Hospital, Singapore, the SIG headed by Dr. Calavera, and to all the attendees. So learn and participate, everyone. Marami pong salamat. Thank you, Alma.
Thank you, ma'am. Thank you, Dr. Mirasol. Before I call on our distinguished speaker, I'd like to call Mr. Vincent Lai, the country manager of Parkway Hospital, Singapore, to give a few words.
Good afternoon, ladies and gentlemen. I'm Vincent from Parkway Hospital, Singapore. First, I would like to thank the team for organizing this webinar. I believe some of you have met me and heard my presentation before. COVID-19 has changed our life tremendously, with social distancing and the need to wear a mask when we are in the public. It has also changed the way we work, learn, and play, from attending seminar in person to joining a webinar from the comfort of your house. Parkway Hospitals owns 4 hospitals in Singapore, with multidisciplinary specialty. We have a total of 36 specialties and 1,500 specialists in our hospitals. You will be able to see our specialists for simple to very complicated disease under one roof. The more complex cases we do are liver transplant, kidney transplant, and stem cell transplant, immunotherapy for cancer treatment, using gamma knife and brain path for removing brain tumor, urolith for prostate enlargement, robotic surgery using Da Vinci system for prostate cancer, and the latest IVL shockwave to remove hardened plaque in your artery. Those are some of the latest equipment we have in our hospitals. We are the first in Asia to have PET MRI machine, which is very useful to diagnose complex cancer and for neuro and cardio cases. And its radiation exposure to patients reduces by 70%. We also have a hybrid operating theatre equipped with advanced imaging device for minimally invasive surgery that precision is crucial. Every few years, we will consolidate our clinical quality data and compare with top institutions like Cleveland, Mayo Clinic, and Mount Sinai. We actually score better than them in terms of infection rate, surgical complications, and readmission rate. The red line is their baseline performance comparing with our 3 years data at the bottom. For your information, we have been serving more than 100,000 foreign patients outside of Singapore every year. I've introduced some of the complex cases we handled earlier. We also perform deep brain stimulation to treat Parkinson's disease. All our surgeons perform minimally invasive surgery from head to toe because of the significant benefits to our patients. Can you imagine the trauma caused by cutting open the rib cage? We do minimally invasive heart valve replacement without even opening up the chest. We install LVAD for end-stage heart failure, suitable for patients waiting for a heart transplant. For some of the critical cases whereby the patient's heart and lung fail, we will install ECMO to take over the heart and lung function first while giving treatment to them. We have this robotic-assisted procedure, Makoplasty, to perform partial knee replacement. With multidisciplinary specialty under one roof, it's always a team-based approach to manage patients in critical state. All specialists are senior doctors with many years of experience in the public hospital before setting up their own clinic in the private setting. The prevalence for prostate cancer in men is very high, and robotic surgery for prostate cancer we perform is the gold standard. Mount Elizabeth Hospital is very near to Orchard MRT station and located in the prime shopping area with many hotels nearby. I'm more familiar with Novena as I stay near the area. It's also very near to the Novena MRT. Oasia Hotel is just opposite the Mount Elizabeth Novena Hospital. Grand Legals Hospital is near to the Botanic Gardens and Orchard Road, with many hotels nearby as well. We have more than 20 patient assistance centers around the region. We make appointments and direct admission for our patients, give cost estimation for surgery, arrange bed-to-bed hospital transfer from your country to Singapore, assist in insurance claims, travel arrangement, translator, and other services upon request. Last but not least, if you have further inquiries, our office manager are always here for you. Their contact details are in the webinar email sent to you. Finally, I would like to thank everyone here this afternoon and also to our expert speaker. Thank you and have a blessed day. Stay safe, stay healthy.
Thank you, Mr. Vincent, for that introduction regarding the Parkway hospitals in Singapore. So for this afternoon, I have the privilege of introducing Dr. Dawn. So she is a hematologist at Mount Elizabeth Novena Hospital. Her special interests are in leukemia, lymphoma, and multiple myeloma. She received her MRCP from UK in 2008. She completed her hematology training in SGH and was accredited as a specialist in 2013. She is a fellow of the Royal College of Pathologists in UK. She is an adjunct assistant professor at Duke NUS Medical School. So friends, let us welcome Dr. Dawn.
I feel very honored to be invited as a speaker to this event. And it's very nice meeting you, Dr. Alma and Dr. Angeline. And I hope next time we can meet in person. Yeah, so I start sharing my screen, yeah. So this evening, I will be talking about CAR T-cell therapy, which has become an exciting topic over these few years. And so I will be covering what CAR T-cells are and what is the clinical evidence behind the use of this CAR T-cell therapy. And I will briefly cover end-to-end process of the procedure of CAR T-cell therapy. So what are CAR T-cells and why are they so special? Yeah, so it is basically a very special and revolutionized type of therapy. And it is part of the cell therapy because we use living cells. But then on the other hand, these cells are modified genetically and can be considered as a therapeutic product. So it is considered as a living drug. And T cells, as we all know that T cells are immune cells. So it is also considered as one of the immunotherapies. And on the other hand, these CAR T cells are very specific in finding their targets. So it can be considered as targeted therapy as well. And last but not the least, it is a very individualized and personalized therapy, because at this point in time, autologous CAR T cells are approved. So the cells come from the patient, and these cells are genetically modified to become a CAR T cell product. So it is a very individualized and personalized therapy. Okay, so in this cartoon, I'll just explain the principles behind how CAR T cells work. So a tumor cells usually expresses specific antigen, and our normal T cells, okay, part of the immune system, usually they express T cell receptors, but the normal T cell receptors can't recognize the specific tumor antigen directly. So to make these T cells to be able to directly recognize the tumor specific antigen, what we do is we collect the T cells through the process called apheresis. And then in the laboratory, these cells will be genetically modified to be able to make them produce the chimeric antigen receptors on the surface. So these chimeric antigen receptors are now able to detect the tumor-specific antigen, and the T cells will be brought to the tumor cells directly to the tumor site, and the destruction of the tumor cells will happen. Okay, so anti-CD19 CAR T cells are the very first CAR T cells to be approved by the FDA for the therapeutic use. So why is CD19 selected? So we know that CD19 is widely expressed in almost every stage of B cells along the B cells ontogeny, from the very earliest B cells, which is pro-B cells, all the way to mature B cells right before they turn into plasma cells. And CD19 is very highly expressed in these cells, including the tumor cells originating from the B cells. Even in comparison with CD22 or CD20 expression, CD19 expression is stronger, and it covers wider stages of B cells. And on the other hand, we are also very familiar with managing the patients with B cell lymphopenia, especially after the use of anti-CD20 monoclonal antibodies, which we have been using for more than almost 2 decades. So we are very familiar with managing these patients having B lymphopenia. So with that, anti-CD19 has become the very first target in the development of CAR T cells, and anti-CD19 CAR T cells are the first to be approved by FDA for the clinical use. So these are the detailed structures of the chimeric antigen receptor. So why is it called chimeric? So it is a combination of B cell receptors and the T cell receptors. So if we look at the chimeric antigen receptor structure, there is an extracellular component, there is a transmembranous component, and the intracellular component. And in the extracellular component, there is this single chain variable fragment of the immunoglobulin, which is constructed genetically in the laboratory. And it is very specific to the tumor antigen, which is the target, and this will be able to recognize the target antigen directly. And it is linked to the intracellular component, which is basically the zeta chain of the CD3 molecule. And from the second generation onwards, co-stimulatory domains are added so that these CAR T cells are activated and they can last longer in vivo. Okay, so here I mentioned about co-stimulatory domains. So in our immune system, we know that in all these immune cells, they work together, and their immune regulation is very tightly controlled with the inhibitors as well as stimulators. So we all know that this PD-1 and PD-L1 interaction will lead to immune inhibition. Likewise, CTLA4 and PD-1 interaction will also lead to inhibition. And on the other hand, CD40 antigen and ligand interaction will lead to activation of the T cells and then eventually the cell death of the target cells. So using this, the T cells from the host is modified genetically to produce these co-stimulatory domains, which is linked to the CD3 receptor, and which is again linked to the extracellular component of the B cell single chain variable fragment of the immunoglobulin, and hence they are now expressing chimeric antigen receptors. Okay, so these are the generations of CAR T cells. So the very first generation has very simple structure with CD3 zeta chain and single chain variable fragment. However, because of the lack of the co-stimulatory domains, these cells do not last long in vivo. So therefore, from second generation onwards, these co-stimulatory molecules are added like CD28 or 4-1BB. And in third generation CAR T cells, 2 co-stimulatory domains are added. And fourth generation is now in the clinical trials, and they include these cytokine transgenes. So in addition to the chimeric antigen receptor, there are like these cytokine transgenes included, and the T cell will be able to secrete these cytokines in the tumor environment. So some of the tumor cells may not express the target antigen, or may not express the target antigen at a high enough level to be recognized by this variable fragment, but they will be destroyed with the release of the cytokines from the cytokine transgene. So that is the principle behind the fourth generation CAR T cells. So now we look at the clinical background clinical evidence. Okay, why CAR T cell therapies are like a hot topic and exciting therapeutic development in the field of hematology. So this data is for patients suffering from B acute lymphoblastic leukemia. So the left hand side, on the left hand side, this Kaplan-Meier curve, I'm very sure we are very familiar. So these survival curves show the outcomes of patients who were newly diagnosed with acute B lymphoblastic leukemia and who were treated with first-line therapy. And we can see that, decade by decade, the results are better, that there is like outcomes are improved. And even at in 1990s, the outcomes were relatively good compared to acute myeloid leukemia patients, compared to patients suffering from acute myeloid leukemia. So you can see the survival is above 80%, and recently is more than 90%. So most of the patients, they do well with the first-line therapy. However, like 10 to 20% of the patients who either do not respond to the first-line therapy or refractory, okay, to the first-line therapy, or who relapse after the treatment with the first-line chemotherapy, the outcome is poor. This is shown in the curve, which is on the right-hand side, and it's very bad. Okay? It's the long-term survival is less than 10%. So what happened to to these patients if they have the chance to receive CAR T cell therapy? So based on the Iliano trial, so Iliano trial, it is the clinical trial using Tisagenlecleucel, which is now the therapeutic product named Kymriah by Novartis. So this is the very first clinical trial using anti-CD19 CAR T cell, which is the Tisagenlecleucel, and given to the pediatric and adolescent patients with relapsed refractory B acute lymphoblastic leukemia. So I'm sure you remember the survival curve on the left, on the right, which is very poor, but for the similar group of patients in Iliano trial, the outcomes are amazing. At 12 months of follow-up, 76% survived, and beyond that, at 24 months of follow-up, overall survival rate is 66%. So which is a significant increment in the overall survival as the outcome. So simply put it, 7 out of 10 patients are still alive 2 years after treatment. And the treatment involves a single one-time infusion of these CAR T cells. And What about the adult population with relapsed refractory B acute lymphoblastic leukemia? So ZUMA 3 trial using another CAR T-cell product again showed favorable outcomes, even though in adult patients the outcomes are not as good as the pediatric population. Still, it is much better compared to the historical data. And another disease, okay, so in addition to B acute lymphoblastic leukemia, this diffuse large B-cell lymphoma is another condition, another indication to use CAR T-cell therapy in the clinical setting. Why is this so? So we all know in diffuse large B-cell lymphoma, with the first-line treatment, about 60% of the patients will achieve cure and will remain disease-free. However, about 40% will have either primary refractory disease or will have relapses. Then when a patient with diffuse large B-cell lymphoma relapses, based on this SCHOLAR-1 study, we all know that the outcomes can be very dismal for a certain group of patients. And in overall long-term survival rate is less than 20%. So in these patients, then Tisagenlecleucel, again, which is the Chimeric product, is given, and the overall response rate of 52% was seen with a complete remission rate of 40%, and the duration of response was long, beyond 50%. And if the curves, the one significant thing about these curves is that for patients who have responded to this CAR T-cell therapy, they remained in remission for a period of time, rather than the curves continue to drop. So after a sudden drop at the initial stage, the curves tend to plateau, which shows that the patients who have responded well, they continue to survive on a long-term basis. And this, of course, we know that we are not supposed to compare the across clinical trials, but then the outcomes are like starkly different and very significant. If we look at the conventional chemotherapy and autologous stem cell transplant on the left-hand side to the CAR T-cell therapy on the right-hand side for the patients with diffuse large B-cell lymphoma. And Associa is another CAR T product. Okay. So these are the major anti-CD19 CAR T-cell products available for the treatment of relapsed refractory diffuse large B-cell lymphoma and relapsed refractory B acute lymphoblastic leukemia. So Associa and Tisagenlecleucel, they are approved by FDA. And in Singapore, Tisagenlecleucel is approved and Associa is in the process of getting the approval. And now, especially in diffuse large B-cell lymphoma in the relapsed refractory setting, these CAR T cells are challenging the role of salvage therapy and autologous stem cell transplantation. So several clinical trials have performed, and we all know from the results presented in last ASH, ZUMA 7 trial, it shows significant improved outcomes compared to the patients who received salvage chemotherapy and autologous stem cell transplant, which was the standard of care therapy. So in summary, in relapsed refractory diffuse large B-cell lymphoma, the data is very convincing that CAR T-cell therapy is beneficial for the prolonged survival of the patients, and it is now challenging the conventional approach of autologous stem cell transplantation in the relapsed refractory diffuse large B-cell lymphoma. And it is giving the patients the benefit to enjoy a durable response. And not only, in the B cells, acute lymphoblastic leukemia and diffuse large B-cell lymphoma, it is now expanding the role to the treatment of multiple myeloma as well, which are, after all, the mature B cells, at the end of the B cell maturation. But for plasma cells, especially in the clonal plasma cells, they do not express CD19. So another target is chosen, which is this BCMA, B cell maturation antigen, which is universally expressed in the myeloma plasma cells. And there are several trials and recruited very high-risk patients who, if we look at it, most of the patients are triple refractory. Triple class refractory means they are refractory to proteasome inhibitors and IMiDs and anti-CD38 monoclonal antibody therapy. And they included patients with high risk, very high risk cytogenetics as well, high tumor burdens, and many lines of therapy previously. And despite that, the outcomes are very encouraging, especially in the CARTITUDE trial, which is the product called Cytocel by J&J and Legend. So the overall response rate is 100%, and the complete remission rate is like extremely high, 86%. And with that significantly improved outcomes, progression-free survival is not reached yet. Okay, so now I move on to the third part of the talk, which is the overview of end-to-end process of the CAR T-cell production and the therapy. So what do we do? So from the start of the procedure, we need to select which patient is suitable for CAR T-cell therapy. So it will be done by the primary hematologist of the patient. And if the patient is deemed suitable to receive CAR T-cell therapy, the patient will be sent to the apheresis unit to harvest the T cells. The harvested T cells will then be transported to the local laboratory for the processing, and then from the local laboratory, it will be shipped. It will be transported to the central manufacturing site, depending on the product where the central manufacturing site is depending on the product. And at the site in the manufacturing laboratory, these T cells will undergo genetic engineering process with the transduction, and then culture and expansion, and then finally they will undergo another harvest. And after quality control is ensured, the product will be released to be shipped back to the clinical unit, which will be in another country. And at the clinical unit, while waiting for this product to be shipped back, the patient will be undergoing the preparation. Okay, so if some patients may need bridging therapy to control the disease while waiting for the CAR T-cell production to be completed, and some patients who are ready to be infused with CAR T-cells, they will need to undergo lymphodepleting chemotherapy, which I will elaborate a little further on. And eventually, CAR T-cell infusion will occur, and subsequently, the patient will be followed up on a long-term basis with the evaluation of the disease, as well as the monitoring of complications arising from the CAR T-cell therapy. Okay, so this is the chain of process in Parkway Cancer Center. So our apheresis unit is located in the Parkway hospitals, one of the Parkway hospitals which Mr. Vincent Line has mentioned, either Mount Elizabeth Novena Hospital or Orchard. And the patient will be admitted to the apheresis unit on the day of harvest, and the T cells will be harvested, and the product will be sent to the local laboratory, which is then called Laboratory for Processing. And depending on the requirement by the manufacturer of the CAR-T, for example, for Chimeric, they need us to freeze the CAR T cells. They need us to freeze the T cells, okay, before shipping the T cells to the manufacturing site. So the stem cell laboratory will freeze the T cells down, and then it will the T cells will be shipped in the cryo shipper to the manufacturing site, which is in the United States. And after the CAR T-cell manufacturing at the central laboratory, the product will be shipped back to the Parkway Cancer Center. And if the patient is not ready to receive the product yet, the product will be stored back again in the stem cell laboratory, which is our local laboratory. And when the patient is ready to receive CAR T-cells infusion, then the product will be transported from stem cell laboratory to the hospital. Okay. So first, as I have mentioned, the patient must be selected very carefully to ensure that that patient is safe enough to receive this kind of therapy. So inclusion and exclusion criteria, we follow the clinical trial inclusion and exclusion criteria. So roughly, for B-cell acute lymphoblastic leukemia, there is an age limit, which is like children and adolescents up to, and young adults up to 25 years. And relapse refractory disease patients could have received allogenic stem cell transplantation and now is having relapse disease. And if the patient with B-ALL is Philadelphia positive, or the treatment with TKI must have failed, and only after that the patient can receive CAR T-cell therapy. As for diffuse large B-cell lymphoma, in the clinical trial, specific types of diffuse large B-cell lymphomas are not included, like primary mediastinal B-cell lymphoma or cutaneous large B-cell lymphoma. But in the clinical setting with the commercial use, we will evaluate the patient, and depending on the case-by-case basis, we may accept the patient and we may deem the patient suitable to receive CAR T-cell therapy, even if the subtype, a specific subtype of diffuse large B-cell lymphoma was not included in the clinical trial. One requirement is that we prefer the patient to go for the T-cell harvest before they receive any kind of lymphodepleting therapy, and we would like to see the absolute lymphocyte count of more than 0.2 times 10 to the power 9 per liter. And of course, there will be the standard screening of infectious diseases and organ functions before they receive lymphodepleting therapy or T-cell infusion. And bridging therapy, I mentioned briefly, it is also an important step in the management of these patients, because the whole CAR T-cell production, it can take up to a few weeks. So for example, in for the product Chimeric, it takes about three weeks for the CAR T-cell to be ready and to be shipped back to Singapore. So during that period, if the patient disease progresses, or if the patient has a very high disease burden, we prefer to give bridging chemotherapy. So for example, for acute B lymphoblastic leukemia, we use standard chemotherapy, or we, if bispecific T-cell engagers are available, like Tumour, it can be used. But here one aim is that the use of bridging therapy is to control the disease, and so that we can bring the patients to receive CAR T-cell therapy, rather than to eradicate the disease completely and to render the patient's MRD, minimal residual disease negativity. Because the principles behind how CAR T-cells works is that they need targets. So we still need some tumor cells in the patient, so that the T-cells, these chimeric T-cells with chimeric antigen receptors, after they are infused into the patient, so that they can still find the tumor targets and they can carry out their mission. Yeah, so if we eradicate the disease completely and MRD is negative, then the purpose may be defeated. And of course, some studies have shown that those who have responded well to the bridging therapy, the outcomes after receiving the CAR T-cell infusion is better compared to those patients who do not respond well to the bridging therapy and instead go into CAR T-cell infusion with high disease burden. Okay, so these are some standards that we follow. So after receiving the bridging therapy and before the CAR T-cell infusion, the patient, all the standard treatments like steroids or DLI, donor lymphocyte infusion, or GVHD therapy if the patient has received prior stem cell transplantation, or CNS prophylaxis, radiation, or even anti-T cell therapy, all should be stopped before the CAR T-cell infusion. And then when the patient is ready, we will give them lymphodepleting therapy. So the purpose of lymphodepleting therapy is different from bridging therapy. It is not to not to target the tumor cells. It's basically to create the favorable immune environment in the patient, so that the patient can receive CAR T cells well, and the CAR T cells, after being infused into the patient, they can live and they can expand and they can last for a long time. So the lymphodepleting chemotherapy, the agents that we use usually for lymphodepleting chemotherapy include fludarabine or cyclophosphamide, and depending on the centers, the dose may differ slightly, but more or less, the purpose is to render some lymphodepletion so that the immune environment is favorable to receive CAR T cells. You can choose not to give this at all if the absolute lymphocyte count is less than 0.2. And of course, by receiving lymphodepleting therapy, there will be additional risk of infections, additional risk of cytopenias in the patient. And so now the patient is ready to receive CAR T-cell infusion. So this is like an overview of the processes. So this is really not anything technical, but I would say more of logistical issues. So starting from the prescription of the order all the way to shipment to manufacturer, and then we receive the cryo shipper containing the product, and then this cryo shipper will be transferred to the storage facility until the patient is ready to be used. Then the product will be transferred again to the clinical unit to be thawed so that the product can be infused into the patient. So it involves multiple steps with various personnel and various teams. So it is very important to follow the standard operating procedures and to have documented the practice of documenting every step of the process. So like starting from the receiving of cryo shipper, and then how we perform the conformity check, including checking the travel documents and labels and temperature logs, etc., all the way to patient identity and checking for the visible damage, leakage, including the cryo shipper and the product. These are very important steps. Nothing scientific, but it's just logistic. But this is very important in the quality control of the whole CAR T-cell therapy. And all these checks must be done by at least 2 team members. And at every step, we must ensure that there is the chain of custody is intact. And again, as I've mentioned, the product, after receiving the product from the manufacturer side, the product will be first stored in the local laboratory. So the local laboratory must also be accredited and equipped with the ability to store these products. And there must always be backup tanks and contingency plans in case of any failure of any storage facilities. And at the same time, thawing of the product right before the infusion, we have to follow the standard operating procedures, and every step must be documented, tightly quality controlled. And for the product Kymriah, after thawing, it is stable at room temperature for 30 to 90 minutes. And within that period of time frame, it has to be infused into the patient. So usually, so the CAR T-cell infusion, it happens in the hospital ward. And of course, the hospital has to be a tertiary hospital. It has to be equipped with a ICU management as well as other supportive care like pharmacy and multidisciplinary team members, including respiratory physician, neurologist, infectious disease specialists. And infusion usually take place in the general ward setting in the patient room. Is like how we usually infuse our stem cell product by a trained stem cell transplant nurse. And of course, product check will be again, performed as the final step right before the infusion. So we talk about how good the CAR T-cell therapy is and how it can improve the outcomes of the patients, but at the same time, it is a high-risk type of therapy. It can come with side effects, including cytokine release syndrome and the neurotoxicity. So it is also very important if we are providing CAR T-cell therapy to the patients, we need to be trained, including the doctors and the nurses and pharmacists. We need to be trained on these, how to monitor the potential complications and what are the signs and symptoms of cytokine release syndrome, how to recognize them, and we need to be equipped with the drugs and the settings, the facilities to manage the patients having these complications. So cytokine release syndrome, which is basically like overwhelming immune response, because these CAR T cells are activated T cells, and once they go in and find the tumor target, they will start destroying the cells, and along the process, all the cytokines will be released, and it can lead to fever, all these overwhelming immune response leading to hypoxia, hypotension, and if it is not managed properly, it can lead to multi-organ failure. So it's like these are how we grade cytokine release syndrome, and depending on the grade, if it is mild, we manage with supportive care, but if it is severe, the patient may need interleukin-6 inhibitors like tocilizumab. And another significant potential complication is, of course, ICANS, this neurotoxicity induced by these immune effector cells. The underlying pathophysiology is not very well understood. It's a little overlapping with cytokine release syndrome. However, in some patients, it can be isolated adverse reaction. So these patients are closely monitored with a neurological scoring system. We can use any score or any guides available. But the thing is, the team must be very familiar with these monitoring system and must perform very diligently and must monitor the patient. And of course, we have to preempt the neurologist, and the neurologist has to come in and manage as early as possible if there are signs of ICANS. And for the long-term follow-up, the patient will be monitored closely for the initial first 30 days, and beyond that, if the patient is stable to be discharged from the hospital, the patient will be discharged and follow up as outpatient. So at that point in time, the disease will be reassessed, the response to the treatment will be reassessed. And at the same time, we monitor the expansion of CAR T cells in vivo. So here we have in-house the flow cytometry assay to quantify the CAR T cells, the remaining CAR T cells in the blood. And we also have next generation sequencing, detecting the transgene of the anti-CD19 CAR T, which is developed in-house. So in summary, CAR T cell therapy has revolutionized treatment of acute B lymphoblastic leukemia and aggressive diffuse large B-cell lymphoma. And of course, it modifies and enhances our own body system to kill the blood cancer cells. And definitely it will expand its role in multiple myeloma, as well as other non-Hodgkin B-cell lymphoma, as well as other solid tumors. And beyond the autologous CAR T cells, there's always a possibility of having allogenic CAR T cells products or allogenic NK T cells products. So that is in the horizon, and we just have to wait and see. So this is the whole team, which is committed to the CAR T cell therapy in the Parkway Cancer Center, including the hematologist, transplant coordinator, quality team, nursing team, and the operation team, and of course the pharmacist. Okay, with that, I will conclude my talk today. Thank you very much for your attention. And yeah, please feel free to ask any questions.
Thank you, Dr. Dawn, for that wonderful lecture. So I think we have one question in the chat box. It's what advantage does NK cell infusion over regular CAR T cell infusion and experience with it so far?
If you are talking about CAR NK cells, we don't have any experience. But if we are talking about donor NK cells, here the common practice is donor lymphocyte infusion. So these are like completely different type of therapies, and donor NK cells are basically allogenic NK cells, and usually done after allogenic stem cell transplantation. And at this point in time, for CAR T cell therapy, we have autologous CAR T cell therapy product, which is Chimeric. So I think we are talking about two different types of therapy for different diseases, I think. So I don't think we can compare these two types of therapy. Yeah. What do you think, Dr. Alma? I'm very sure your experience is immense, yeah, in the stem cell transplantation. Yeah.
For stem cell transplant, but for NK, no. I don't know what they're talking about also. I don't know if that is the, because you can cytokine induce an NK T cells, right? Before giving it to the patient, but NK cytokine induced natural killer T cells that you are infusing to the patient is not as specific as the chimeric antigen receptor, which targets the CD19.
Yes.
So maybe it's very difficult to compare those two treatments.
Yeah.
The behavior of an NKT is very much different from the CAR T.
Yes, yes. And usually cytokine-induced NK cells, they are allogenic cells. Yeah.
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 Because it's hard if you're going to get it from an ongoing malignancy. I think the quality of those NK will not be as good.
No.
Yeah.
Yeah. Yes.
So I think there are no more questions, but I'd like to ask a question. So in one of the slide you showed, although CAR T cells is an effective treatment compared to the standard of care, but if you look at it, it's still only 40% response rate or CR rate. It's not that good yet. So what do you think are the other things we can do to improve the response to CAR T?
Yes, thank you very much for such a great question. Yeah, so I won't even say that this is a question. I think this is a point to discuss further. Yeah. So definitely, so I think this is the first step to the improvement. Yeah. But of course, there is more room. There is more that we need to do, maybe in terms of research, as well as how we time the CAR T cell in therapy, in the whole treatment timeline. Okay, so what the discussion is focusing now is the use of CAR T cells in very high risk population of patients who have received, heavy chemotherapies, and in the relapse refractory settings when the disease is a bit more resistant. So one thing to overcome this poor, I would say rather relatively poor outcomes, maybe is to bring the CAR T cell therapy a little earlier in the line of treatment. Yeah. So right now, with multiple myeloma in the CAR-T2 trial, there are like 2 cohorts which are basically using the CAR T cells in the upfront setting. So one cohort is newly diagnosed with very high risk cytogenetics. Okay, so we know multiple myeloma patients with high risk cytogenetics, no matter what we give in whatever clinical trials, even including Griffin, the outcome is still poorer compared to the standard risk multiple myeloma patients. So in this kind of patients, how the trial is designed is that we give them the best available treatment, which is 4 drugs: daratumumab, Velcade, and lenalidomide, and then induce remission, and then collect the T cells and produce CAR T cells, and then infuse the CAR T cells rather than doing the autologous stem cell transplantation. So basically, we are bringing the CAR T cells to the upfront treatment, and with that, we are hoping, that the outcome may be better, or even in multiple myeloma, perhaps we may achieve some kind of cure.
Yeah.
I think it's the same for diffuse large B-cell lymphoma and acute B-lymphoblastic leukemia as well. Yeah, so I think I'm very sure in future there will be more such trials conducted and more data for us to look at and use for our patients.
Yeah, I agree. So I think in the future we'll see that maybe CAR T will be used as an upfront treatment rather than later to improve the outcome. Maybe better construct of the CAR T, more persistent CAR Ts that are persisting longer, CAR Ts with multiple targets so that we can have better outcome. Maybe another question is, CAR Ts is very expensive. I have one experience, a patient who went there to Singapore to have the CAR T. She is a primary mediastinal B-cell lymphoma. She paid it out of pocket. So we were contemplating on whether to use a PD-L1 versus a bendamustine or a CAR T. Of course, if we're going to CAR T, we cannot use the bendamustine because it's a T-cell depleting.
Yes.
So eventually she went, and it was very successful. She is in remission. So, but the cost is very prohibitive.
I know.
The cost is about, in Philippine peso, about 30-40 million pesos. So that's very expensive. So Dr. Dawn, do you think in the future us Asian countries can make maybe CAR T treatment cheaper? Maybe the way to make CAR T treatment cheaper is we make our own, right?
Yeah, I guess so. Yes.
Yeah, we make our own CAR T rather than having farm. So maybe it's something that Asian countries should do, because we've seen it firsthand that CAR T therapy would do well for our patients.
Yeah,
it's something. I think there's another question in the chat box. So I'll read it. How often do you see CRS side effects in your patients treated with CAR-T, and what is the profile of the patients who develop CRS? But I think these are patients with high tumor burden, right?
Yes, yes. So I would say for so far, I mean, like as you have mentioned, because of the cost, even locally also, like not many patients can, in fact, go into this kind of therapy. So the numbers are limited. But based on this limited number, what I can say is almost all develop CRS, just at the grade. Okay, so most, I would say 2/3, the grade is low, grade 1 or grade 2. And they don't need to go to intensive care unit. However, about 30%, it is severe, grade 3 or 4, and they need intensive care support with inotropic support. And it is the same for ICANS. And like it is, you said it right. It is. I think that it is related to the disease burden, and the higher the disease burden, the stronger the cytokine storm is, and patient will suffer from more severe CRS or ICANS. Yeah.
So thank you, Dr. Dawn. I think there's another question. When would CAR T-cell therapy be superior to transplant in relapsed B-cell ALL in the pediatric population? Could these therapies be used in combination in some cases, or is CAR T therapy for pedia conditions available locally?
Yes. So, okay. Number one, I have to admit that I'm not a pediatric hematologist, but then based on our meetings and with our pediatric colleagues, what I have learned is, yes, we do bring forward the CAR T-cell therapy over stem cell transplant sometimes. I have seen them discussing and bringing forward the CAR T-cells therapy before doing the stem cell transplantation. So I think it really depends on the patient's risk profile. And I'm very sure, here, if there are pediatric colleagues are there, in some of the patients, that even if you offer allogenic stem cell transplantation, the outcome can still be dismal. So in this kind of setting, CAR T-cell can be used. And on another setting that I can think of is the fitness of the patient. So if you really compare the allogenic stem cell transplantation and CAR T-cell therapy, patients, I would say CAR T-cell therapy is much less intensive. So most of the patients can tolerate this therapy, especially pediatric population. So I have seen here, in Singapore, pediatric hematologists, they practice in heavily pretreated patients who have suffered from several infectious complications, and the risk of allogenic stem cell transplantation in that kind of population is very high. Then they bring forward the CAR T-cell therapy. And yes, you can consider after CAR T-cell therapy, if the tumor still breaks through and relapses, we can consider stem cell transplant, or vice versa for B acute lymphoblastic leukemia.
Thank you, Doctor. So maybe just to summarize what you said is that it's very hard to compare CAR-T and allogeneic stem cell transplant. It should be patient-based. Depends on the tolerability of transplant and their characteristic. Maybe weaker patients who cannot tolerate allogeneic will do better with CAR-T cell, but there are certain risk stratification that won't do well with CAR-T. I think one example is the MLL gene mutation for ALL. Those patients would definitely need a transplant, and even CAR-T, they won't respond. So another question that came in was that, how about off-the-rack CAR-T? I think they're talking about allogeneic CAR-T, right? If this is off the rack.
Yes, yeah.
So I think this is ongoing clinical trials, right, for this?
Yeah, but we do not have any allogenic CAR-T products in the trials in Singapore. Probably the patients have to explore somewhere else overseas. Yeah.
There are ongoing trials from what I know of, like for example in Spain, but what they told me is it's still not working. Too far from clinical use.
Yeah,
it's still not working with the animal models.
Yeah.
And they said that if it is available if it's available, it's going to be very expensive. So the cost will be very prohibitive. The only way maybe a country like the Philippines can afford it is we make our own.
Yeah. It's the same. It's the same for us. And there are a few labs here in Singapore which are trying to build their own.
Yeah.
Yeah.
I think everyone is.
Yeah. I think so. Yeah.
Okay, but we need to build on expertise, right? As what Dr. Dawn said, it's really a multidisciplinary team to build a CAR-T program.
Yeah. Which I guess you can expand your stem cell transplant team and grow into CAR-T team as well.
Yeah. Thank you, Dr. Dawn. But for now, if we do have patients who are in need of CAR-T, so like me, I had one experience who went to Singapore and she's doing very well.
Sure. Yeah.
Okay, so I think, Dr. Dawn, we're only allotted 20 minutes and we've already consumed it. So in behalf of PCHTM, we're very grateful for your lecture. We learned a lot during this evening. Thank you very much.
Thank you. Yeah. Very nice meeting you again.
Very nice. Okay, thank you.